Welcome to this program by The Ohio State University on coordination of care for the early identification of lung cancer that was presented by a panel of experts from the university. Each panelist spoke about a different topic in the early identification of lung cancer. In this video, Dr. Jasleen Pannu discusses the importance and management of incidental pulmonary nodules.
My name is Jasleen Pannu. I'm an interventional pulmonologist at Ohio State, and I'm setting up a lung nodule program at James at Ohio State. I'm going to talk about the importance and management of incidental pulmonary nodules today. I like to start with a real-life example because I think that's what tells the story most impactfully. On your left of the screen is the scan of a patient who came with abdominal pain. This was supposed to be a CT abdomen, and there's an incidentally detected nodule peripherally on the left here. In the period of about 1 year, the patient ends up having repeated episodes of abdominal pain, some abdominal surgeries, and has about 6 CT scans. On some scans, this spot is detected red, sometimes it's not. And it's not until April of next year that the referral to the local pulmonologist is made for the lung nodule. And as you can see, the nodule by that time has considerably grown. It's not until 3 months later that he gets a PET scan. A month forward, then the patient gets a CT-guided biopsy where adrenal lesion was also detected in addition to the lung mass. Then a radiation oncology referral is made, and then an oncology referral is made eventually because the patient was stage 4 to begin with when the PET scan was done in July 2020. So this presents a real-life story of how incidental detections are made, and when we miss them, difficult things can happen. Countrywide, there are about 5 million scans done in a year, and incidental nodule detections can be detected on 160,000 of them. We don't follow about 114,000 of these cases. And while the number 4% seems quite small, but if you see the scale of the number of detections we make, that's approximately 4,500 detections of early cancer that we may be missing. If the follow-up was more organized, it's more consistent, more early-stage lung cancers may be identified, and we now know from the data that we know that the way to influence lung cancer mortality is to detect it early. We at Ohio State conducted a retrospective study of how we were following up our incidental lung nodules. Our criteria of exclusion was slightly different. We eliminated around 14,000 because of our exclusion criteria. And there were about 696 patients who had first-time detected incidental nodules with no other history of any active cancer. Our primary outcomes were to see how many times we are appropriately following these nodules and what are the factors that can be behind lack of appropriate follow-up. As a secondary outcome, we wanted to look at any sentinel events or misdiagnosis in IPN. And what we found was also striking. We found that at Ohio State, we are missing more than half of the patients without giving them appropriate follow-up. 57% of all patients did not have appropriate follow-up of incident pulmonary nodules. Of the total number of patients, if we looked at chest, abdomen, and neck CTs, if the nodule was detected on neck and abdominal CT, the chances of missing the nodule were even higher. It's up to 80% if the nodule was detected on the CT of neck. Oftentimes, we blame the emergency department about missing these nodules. Patients go in and out, they get a CTPE, and we may miss the nodule. But that's not always true. If the radiologist fails to mention the presence of a nodule in the final impression and mentions it somewhere in the body of the report, there is about 95% chance that they miss it. What kind of nodules are we missing? There was a lot of talk about missing really small nodules or very low-risk nodules, and the fact that we don't miss high-risk nodules. That's to some extent maybe correct, that yes, the low-risk nodules are missed more and the high-risk are missed less, but they are missed nevertheless. The most nodules that get missed are the intermediate risk, means the risk is about 5 to 65% of having lung cancer, and that's a pretty broad category. So that's the majority of patients that we are missing. In prior studies, also, this data has been reinforced. Approximately 2 out of 3 patients with incidentally detected pulmonary nodules received no clinical follow-up, and about no follow-up at all if the report did not mention the findings in the impression of the report. In one large study where they calculated the mean time from the initial diagnosis of the pulmonary nodule to the first workup was about 8 months. And it could be because it was missed initially and later referred until it finally caught somebody's attention. The Fleshner guidelines are important because this is what is used by radiologists as well as pulmonologists to recommend appropriate follow-up. These are important guidelines to follow because they are evidence-based guidelines to make sure that there is appropriate follow-up according to the size and the risk of the nodule. I'm not going to go into those guidelines in detail, but I'm going to just briefly touch on the barriers again. Barriers to follow-up are varied, and they are multiple circumstances, and they are very local. Every single hospital may have a different barrier that has to be addressed locally. And it could range from inadequate information to counsel patients, time constraint, lack of system-wide procedures, lack of knowledge, insufficient resources, and excluding the patients from shared decision-making to begin with. So what's needed is to develop comprehensive, multidisciplinary strategies with the support of multiple departments, including pulmonologists, radiologists, and to improve the PCP's knowledge about how to treat these nodules, when to refer the nodule, to notify the patient on time, and to involve the patient in shared decision-making. We tried to learn from the lessons we got from our study, and we have tried to put forward a comprehensive multidisciplinary lung nodule program at The Ohio State University. What we have are multiple steps so that we don't miss cases and the cases don't fall through the cracks. We realize that the volumes that we see are very large, and this may be difficult to keep up manually. So we are investing in an automated system, a software that compiles a list of all incidental nodules through natural language processing throughout the system. When the nodule meets criteria, a weekly triage is done, and the patient is offered a choice to be referred to the lung nodule clinic. And it doesn't end there, because the management of these patients is very multidisciplinary. It may involve back and forth between different systems. Interventional pulmonologist may do a biopsy, then the thoracic surgeon may resect it, or there may be a radiation oncologist involved who needs to give SBRT. There may be some follow-up involved or PET scans involved. A lung nodule board is held every week since the initiation of this clinic, and which involves pulmonologists, interventional pulmonologists, thoracic oncologists, thoracic surgeons, radiologists. An overall plan of these patients is charted so that a fast-track referral system can be started, and the patients can get to point A from point B at a fast rate.
Look for more videos on the early identification of lung cancer from experts at The Ohio State University.